Hello everyone, and welcome back to another chapter of Advanced Pharmacology. Today we're talking about Chapter 22, Opioid Analgesics, Opioid Antagonists, and Non-Opioid Centrally Acting Analgesics. So, Chapter 22. Analgesics are drugs that relieve pain without causing a loss of consciousness. In this chapter, we focus mainly on the opioid analgesics, the most effective pain relievers available. The opioid family, whose name derives from opium, includes such widely used agents as morphine, fentanyl, codeine, and oxycodone, also known as Oxycontin. So, opioid analgesics. The introduction. The terminology an opioid is any drug, naturally or synthetic, that has similar actions to those of morphine. The term opiate is more specific and applies only to compounds that present in opium. The endogenous opioid peptides. The body has three families of peptides: enkephalins, endorphins, and dynorphins that have opioid-like properties. Although we know that endogenous opioid peptides serve as neurotransmitters, neurohormones, and neuromodulators, their precise physiologic role is not fully understood. Endogenous opioid peptides are found in the central nervous system and in the peripheral tissues. So, opioid receptors. There are three main classes of opioid receptors, designed mu, kappa, and delta. From the pharmacologic perspective, mu receptors are the most important because opioid analgesics act primarily by activating mu receptors, although they also produce weak activation of kappa receptors. As a rule, opioid analgesics do not interact with delta receptors. In contrast to opioid analgesics, endogenous opioid peptides act through all three opioid receptors, including delta receptors. Important responses to activation of mu and kappa receptors are shown in the following table, which is an excellent spot to hit pause so you have a better familiarity of which will work on mu receptors versus your kappa receptors. So, mu receptors. Responses to activation of a mu receptor include analgesia, respiratory depression, euphoria, and sedation. In addition, mu activation is related to physical dependence. A study in genetically engineered mice underscores the importance of mu receptors and drug action. In this study, researchers studied mice that lacked the gene for mu receptors. When these mice were given morphine, the drug had no effect. It did not produce analgesia or physical dependence, and it did not reinforce social behaviors that are thought to indicate subjective effects. Therefore, at least in mice, the mu receptors appear both necessary and sufficient to mediate the major actions of opioid drugs. The kappa receptors. Similar with the mu receptors, the activation of the kappa receptors can produce analgesia and sedation. In addition, kappa activation may underlie psychotomimetic effects seen with certain opioids. So, the classification of drugs that act at opioid receptors. Drugs that act at opioid receptors are classified on the basis of how they affect receptor function. At each type of receptor, a drug can act in one of three ways: as an agonist, a partial agonist, or antagonist. Based on these actions, drugs that bind opioid receptors fall into three major groups: pure opioid agonists, agonist-antagonist opioids, and pure opioid antagonists. These actions of drugs in these groups at mu and kappa receptors are shown here in the following table. Again, it's an excellent spot to hit pause so you can see the drug actions of mu and kappa receptors. So, speaking now on pure opioid agonists. The pure opioid agonists activate mu receptors and kappa receptors. By doing so, the pure agonist can produce analgesia, euphoria, sedation, respiratory depression, physical dependence, constipation, and other effects. The pure agonists can be subdivided into two groups: strong opioid agonists and moderate to strong opioid agonists. Morphine is the prototype of the strong agonist. Codeine is the prototype of the moderate to strong agonist. So, agonist-antagonist opioids. Three agonist-antagonist opioids are available in oral form: pentasokine, butorphanol, and buprenorphine. The actions of these drugs at mu and kappa receptors are shown in Table 22.2. When administered alone, the agonist-antagonist opioids produce analgesia. However, if given to a patient who is taking a pure opioid agonist, these drugs can antagonize analgesia caused by the pure agonist. So, for instance, Talvin or pentasokine is the prototype of the agonist-antagonist. Pure opioid antagonists. The pure opioid antagonists act as antagonists at mu and kappa receptors. These drugs do not produce analgesia or any of the other effects caused by opioid agonists. Their principal use is reversal of respiratory and CNS depression caused by overdose with opioid agonists. In addition, one of these drugs, methyl naltrexone, is used to treat opioid-induced constipation. Naloxone, or Narcan, is the prototype of the pure opioid antagonist. So here you see a list of the prototype drugs that we'll be talking about: morphine, pentasokine, and naloxone. So, basic pharmacology of the opioids. Starting off with morphine. Morphine is the prototype of the strong opioid analgesics and remains standard by which neuroopioids are measured. Morphine has multiple pharmacologic effects, including analgesia, sedation, euphoria, respiratory depression, cough suppression, and suppression of bowel motility. So, looking at the overview then of the pharmacologic action. Morphine has multiple pharmacologic actions. In addition to relieving pain, the drug causes drowsiness and mental clouding, reduces anxiety, and creates a sense of well-being. Through actions in the CNS and periphery, morphine can cause respiratory depression, constipation, urinary retention, orthostatic hypotension, emesis, meiosis, cough suppression, and biliary colic. With prolonged use, the drug produces tolerance and physical dependence. Individual effects of morphine may be beneficial, detrimental, or both. For example, analgesia is clearly beneficial, whereas respiratory depression and urinary retention are clearly detrimental. Certain other effects, such as sedation and reduced bowel motility, may be beneficial or detrimental, depending on the circumstances of drug use. So, the therapeutic use, the relief of pain. The principal indication for morphine is the relief of moderate to severe pain. The drug can relieve postoperative pain, pain of labor and delivery, and chronic pain caused by cancer and other conditions. Morphine relieves pain without causing a loss of consciousness. The drug is more effective against constant, dull pain than against sharp, intermittent pain. However, even sharp pain can be relieved by large doses. The ability of morphine to cause mental clouding, sedation, euphoria, and anxiety reduction can contribute to the relief of pain. The use of morphine and other opioids to relieve pain will be discussed further in this chapter as well as in chapter 83. So, adverse effects. We spoke on this one a little bit already. Respiratory depression. Respiratory depression is the most serious adverse effect. At equianalgesics doses, all of the pure opioids agonists will depress respiration at the same extent. Death after an overdose is almost always from respiratory arrest. Opioids depress respiration primarily through activation of mu receptors. although activation of kappa receptors also may contribute. The time course of respiratory depression begins to 90 minutes after an oral ingestion. With prolonged use of opioids, tolerance develops to respiratory depression. Huge doses that would be lethal to a non-tolerant individual have been taken by opioid addicts without a noticeable effect. Similarly, tolerance to respiratory depression develops during a long-term clinical use of opioids. Certain patients, including the very young, older adult, and those with respiratory disease, are especially sensitive to respiratory depression and therefore must be monitored very closely. Patients should be informed about the risk for respiratory depression and be instructed to notify the prescriber if respiratory distress occurs. So, patient education on respiratory depression. Respiratory depression is increased by concurrent use of other drugs with CNS depressant actions. So, for instance, your alcohol, barbiturates, benzodiazepines. Accordingly, these drugs should be avoided. Outpatients should be warned against the use of alcohol and all other CNS depressants. Pronounced respiratory depression can be reversed with a medication called Narcan or naloxone, an opioid antagonist. However, dosing must be carefully titrated because excessive doses will completely block the analgesic effects of morphine, causing pain to return. So therefore we have a black box warning on all opioids. Opioid medications can cause respiratory arrest in both opioid-naive and opioid-tolerant patients. So monitoring for respiratory depression, especially during new onset therapy or after escalation of dose. Which brings us to the next side effect, constipation. Opioids promote constipation through action in the CNS and gastrointestinal tract, specifically by activating the mu receptors in the gut. These drugs can suppress propulsive intestinal contractions, intensify non-propulsive contractions, and increase the tone of the anal sphincter, and inhibit the secretion of fluids into the intestinal lumen. So as a result, constipation may develop after a few days of opioid use. Potential complications of constipation may include fecal impaction, bowel perforation, rectal tearing, and hemorrhoids. Opioid-induced constipation can be managed with a combination of pharmacologic and non-pharmacologic measures. The goal is to produce a soft formed stool every 1 to 2 days. Principal non-drug measures are physical activity and increased intake of fiber and fluid, as well as enemas. For most patients, may also require a prophylactic drug, such as a stimulant laxative, which would be arsenic or paracolase. It may be given to counteract reduced bowel motility, and again, we may also give a stool softener, which would be your Dococet or Colase, plus polyethylene glycol, an osmotic laxative that can provide additional benefit. If these prophylactic drugs prove inadequate, the patient may need rescue therapy with a strong osmotic laxative, such as lactulose or sodium phosphate. As a last resort, patients may be given methyl naltrexone or Relistor, which is an oral drug that blocks mu receptors in the intestine. As discussed later in this chapter, your methyl naltrexone or Relistor can't cross the blood-brain barrier, so therefore it does not reverse opioid-induced analgesia. Because of their effects in the intestine, opioids are highly effective for treating diarrhea. In fact, antidiarrheal use of these drugs preceded analgesic use by the centuries. The impact of opioids on intestinal function is an interesting example of how an effect can be detrimental or beneficial, depending on who is taking this medication. Opioids employed specifically to treat diarrhea will be discussed further in Chapter 64. Which brings us to the next negative side effect, orthostatic hypotension. Morphine-like drugs may lower blood pressure by blunting the baroreceptor reflex and by dilating peripheral arterioles and veins. Peripheral vasodilation results primarily from morphine-induced release of histamines. So, patient education regarding hypotension. Hypotension is usually mild in the recombinant patient, but can be significant when the patient stands up. Patients should be informed about symptoms of hypotension and be instructed to sit or lie down if they occur. Also, patients should be informed that hypotension can be minimized by moving slowly when changing from a spine to a seated position to an upright position. Patients should be warned against walking if hypotension is substantial. The hospitalized patients may require ambulatory assistance. Hypotensive drugs can exacerbate opioid-induced hypotension. Which brings us to the next side effect, urinary retention. Morphine can cause urinary hesitancy and urinary retention. Three mechanisms are involved. First, morphine increases the tone in the bladder sphincter. Second, morphine increases the tone in the detrusor muscle, thereby elevating pressure within the bladder, causing a sense of urinary urgency. And finally, in addition to its direct effects on the urinary tract, morphine may interfere with voiding by suppressing awareness of bladder stimuli. To reduce discomfort, patients should be encouraged to void every 4 hours. Urinary hesitancy or retention is especially likely in patients who have benign prostatic hypertrophy. Drugs with anticholinergic properties, such as your tricyclic antidepressants and antihistamines, can exacerbate this issue. In addition to causing urinary retention, morphine may decrease urine production largely by decreasing renal blood flow, and partly by promoting the release of antidiuretic hormones. Emesis. Morphine can promote nausea and vomiting through direct stimulation of the chemoreceptor trigger zone of the medulla. Emetic reactions are great with the initial dose and then diminish with subsequent dosing. Nausea and vomiting are uncommon in recombinant patients, but may occur in 15 to 40% of ambulatory patients, suggesting a vestibular component. Nausea and vomiting can be reduced by pretreatment with an antiemetic, such as your prochlorperazine, and by having the patient remain still. Euphoria and dysphoria. Euphoria is defined as an exaggerated sense of well-being. Morphine often produces euphoria when given to patients in pain. After euphoria can enhance pain relief, it also contributes to the drug's potential for abuse. Euphoria is caused by the activation of mu receptors. In some individuals, morphine causes dysphoria, a sense of anxiety and unease. Dysphoria is uncommon among patients in pain, but may occur when morphine is taken in the absence of pain. Sedation. When administered to relieve pain, morphine is likely to cause drowsiness and some mental clouding. Although these effects can complement analgesic actions, they can also be detrimental. Outpatients should be warned about CNS depression and be advised to avoid hazardous activities, such as driving, if sedation is significant. Sedation can be minimized by taking a smaller dose more often or using opioids that have a short half-life. Neurotoxicity. Opioid-induced neurotoxicity can cause delirium, agitation, myoclonus, hyperalgesia, and other symptoms. Primary risk factors are renal impairment, pre-existing cognitive impairment, and prolonged high-dose opioid use. The management consists of hydration and dose reduction. For patients who must take opioids long-term, opioid rotation may reduce neurotoxicity development. So that brings us finally to the pharmacokinetics. With oral morphine therapy, duration of action depends on the formulation. Examples of this are immediate release tablets that can have lasting effects of 4 to 5 hours, whereas the extended release capsules can have lasting effects for up to 24 hours. To relieve pain, morphine must cross the blood-brain barrier and enter the CNS. Because the drug has poor lipid solubility, it does not cross the barrier easily. So, consequentially, only a small fraction of each dose reaches the site of analgesic action, Because the blood-brain barrier is not well developed in infants, these patients generally require a lower dose than do other older children and adults. Morphine is inactivated by the hepatic metabolism. When taken by mouth, the drug must pass through the liver on its way to the systemic circulation. Much of the oral dose is inactivated during the first pass through the liver. In patients with liver disease, analgesia and other effects may be intensified and prolonged. Accordingly, it may be necessary to reduce the dosage or lengthen the dosing interval. Which brings us to tolerance and physical dependence. With continuous use, morphine can cause tolerance and physical dependence. These phenomena, which are generally inseparable, reflect cellular adaptations that occur in response to the prolonged opioid exposure. So let's touch up on tolerance specifically. Tolerance can be defined as a state in which the larger dose is required to produce the same response that could formerly be produced with a smaller dose. Alternatively, tolerance can be defined as a condition in which a particular dose now produces a smaller response than it did when treatment initially began. Because of tolerance, dosage must be increased to maintain analgesic effects. Tolerance develops to many, but not all, of morphine's actions. With prolonged treatment, tolerance develops to analgesia, euphoria, and sedation. As a result, with long-term therapy, an increase in dosage may be required to maintain the desirable effect. Fortunately, as tolerance develops to these therapeutic effects, tolerance also develops to respiratory depression. As a result, the high doses needed to control pain in the tolerant individual are not associated with increased respiratory depression. Very little tolerance develops to constipation and meiosis. Even in highly tolerant addicts, constipation remains a chronic problem, and constricted pupils are characteristics. Cross-tolerance exists among the opioid agonists, so your oxycodone, methadone, fentanyl, codeine, and heroin. Accordingly, individuals tolerant to one of these agents will be tolerant to all the others. No cross-tolerance exists between opioids and general CNS depressants, such as your barbiturates, ethanol, benzodiazepines, and general anesthetics. Which brings us to the physical dependence portion. Physical dependence is defined as a state in which an abstinence syndrome will occur if drug use is abruptly stopped. Opioid dependence results from adaptive cellular changes that occur in response to the continuous presence of these drugs. Although the exact nature of these changes is unknown, it is clear that after the compensatory changes have taken place, the body requires the continued presence of opioids to function normally. If opioids are withdrawn, an abstinence syndrome usually will follow. The intensity and duration of opioid abstinence syndrome depends on two factors: the half-life of the drug being used and the degree of physical dependence. With opioids that have relative short half-lives, such as morphine, symptoms of abstinence are intense but brief. In contrast, with opioids that have a long half-life, such as methadone, symptoms are less intense but more prolonged. With an opioid, the intensity of withdrawal symptoms parallel the degree of physical dependence. For individuals who are highly dependent, the abstinence syndrome can be extremely unpleasant. Initial reactions include yawning, rhinorrhea, and sweating. Onset occurs about 10 hours after the final dose. These early responses are followed by anorexia, irritability, tremor, and gooseflesh, hence the term cold turkey. At its peak, the syndrome manifests as violent sneezing, weakness, nausea, vomiting, diarrhea, abdominal cramps, bone and muscle pain, muscle spasms, and kicking movements. Hence the term kicking the habit. Giving opioid at any time during withdrawal rapidly reverses all signs and symptoms. When left untreated, the morphine withdrawal syndrome runs its course in 7 to 10 days. It should be emphasized that although the withdrawal from opioids is unpleasant, the syndrome is extremely rare and dangerous. In contrast, withdrawal from general CNS depressants such as your barbiturates or alcohol, which can be lethal. So we'll discuss that more in chapter 27. To minimize the abstinence syndrome, opioids should be withdrawn gradually. When the degree of dependence is moderate, symptoms can be avoided by administering progressively smaller doses over 3 days. When the patient is highly dependent, dosage should be tapered more slowly over 7 to 10 days. With a proper withdrawal schedule, withdrawal symptoms will resemble those of a mild case of the flu, even when the degree of dependence is high. It's important to note that physical dependence is rarely a complication when opioids are taken acutely to treat pain. Hospitalized patients receiving morphine 2 to 3 times a day for up to 2 weeks show no significant signs of dependence. If morphine is withheld from these patients, no significant signs of withdrawal can be detected. The issue of physical dependence as a clinical concern is discussed later in this chapter. Infants exposed to opioids in utero may be born drug dependent. If the infant is not provided with opioids, an abstinence syndrome will ensue. Signs of withdrawal include excessive crying, sneezing, tremor, hyperreflexia, fever, and diarrhea. The infant can be weaned from drug dependence by administering dilute paradiuretic in progressively smaller doses. The cross-dependence exists among pure opioid agonists. As a result, any pure agonist will prevent withdrawal in a patient who is physically dependent on any other pure agonist. Which brings us to the abuse liability. Morphine and other opioids are subject to abuse, largely because of their ability to cause pleasurable experience. Again, euphoria and sedation. Physical dependence contributes to abuse. When dependence does exist, the ability of opioids to ward off withdrawal serves to reinforce their desirability in the mind of the abuser. The abuse liability of the opioid is reflected in their classification under the Controlled Substance Act. As shown here in the following table, morphine and all other strong opioid agonists are classified under Schedule II. This classification reflects a moderate to high abuse liability. The agonist-antagonist opioids have a lower abuse liability and therefore are classified under Schedule IV or Schedule III, or have no classification at all. Healthcare personnel who prescribe, dispense, and administer opioids must adhere to the procedures set forth in the Controlled Substance Act. So here's Table 22.3, an outstanding spot to hit pause so you can see the interactions of morphine-like drugs with other drugs. Fortunately, abuse is rare when opioids are employed to treat pain. The issue of abuse is a clinical concern, which is addressed in depth later in this chapter. Which brings us to some precautions. Some patients are more likely than others to experience adverse effects. Common sense dictates that opioids be used with special caution in these people. Conditions that can predispose patients to adverse reactions will be discussed next. So, the first is decreased respiratory reserve. Again, because morphine depresses respiration, it can further compromise respiration in patients with impaired pulmonary function. Accordingly, the drug should be used with caution in patients who have asthma, emphysema, kyphoscoliosis, chronic cor pulmonale, and extreme obesity. Caution is also needed in patients taking other drugs that would depress your respirations. So again, your barbiturates, benzodiazepines, and general anesthetics. We also have some other precautions. Again, infants and older adult patients are especially sensitive to morphine-induced respiratory depression. In patients with inflammatory bowel disease, morphine can cause toxic megacolon or a paralytic ileus. Because morphine and all other opioids are inactivated by liver enzymes, effects may be intensified and prolonged in patients with liver impairment. Severe hypotension may occur in patients with pre-existing hypotension or reduced blood volume. In a patient with benign prostatic hypertrophy, opioids may cause acute urinary retention. which would require repeated catheterization. So, that brings us to drug interactions. The major interactions between morphine and other drugs are shown in the table 22.3. Some interactions are adverse, and some may be beneficial. Which brings us to toxicity, the clinical manifestation. Opioid overdose produces a classic triad of signs. We've got coma, respiratory depression, and pinpoint pupils. Coma is profound and the patient cannot be aroused. Respiratory rate may be as low as 2 to 4 breaths per minute. Although the pupils are constricted initially, they may dilate as hypoxia sets in. Hypoxia may cause blood pressure to fall. Prolonged hypoxia may result in shock. When death occurs, respiratory arrest is almost always the immediate cause. So, how would you treat it? Treatment consists primarily of ventilatory support and giving an opioid antagonist. Again, Narcan or naloxone, which is the traditional antagonist of choice. The pharmacology of the opioid antagonist is discussed later in this chapter. So, different preparations. Morphine alone. Morphine sulfate by itself is available in 8 non-parental formulations, are immediate release tablets, controlled release tablets, extended release tablets, sustained release capsules, extended release capsules, the standard oral solution, a concentrated oral solution, and a rectal suppository. Here is an outstanding spot to hit pause so you can see all the different dosages of all the different types of medications for it. There are a lot, so I'm not going to read each and every single one of them. So that brings us to our combination drugs, morphine and naltrexone, also known as Ambida. In 2010, the FDA approved Ambida, a fixed-dose combination of morphine and naltrexone, an opioid antagonist. The product was designed to discourage morphine abuse. Ambida capsules are filled with tiny pellets that have an outer layer of extended-release morphine and an inner core of naltrexone. When the capsules are swallowed intact, only the morphine is absorbed. However, if the pellets are crushed, the naltrexone will be absorbed too, thereby blunting the effects of the morphine. So as a result, potential abusers cannot get a quick high by crushing the pellets to release all the morphine at once. However, abusers can still get high by simply taking a large dose. Ambida capsules are more expensive than the other extended-release morphine products and should be prescribed only when abuse appears to be likely. Alcohol can accelerate release of morphine from Ambida pellets. As a result, the entire dose can be absorbed quickly, rather than over 24 hours, thereby causing a potential fatal spike in morphine blood levels. Accordingly, patients should be warned against alcohol consumption. These capsules are available in 6 morphine naltrexone strengths. I'll let you hit pause so you can review them. Dosing should be done once or twice daily, and patients can swallow the Ambida capsules whole, or they can open the capsules and sprinkle the pellets on applesauce, which must be ingested without chewing. So that brings us to dosage and administration. Dosage must be individualized. High doses are required for patients with a low tolerance to pain or with extremely painful disorders. Patients with sharp stabbing pain need a higher dose than patients with dull pain. Older adults generally require a lower dose than the younger adult. Neonates require relatively low doses, again because their blood-brain barrier isn't fully developed. For all patients, dosage should be reduced as pain subsides. Outpatients should be warned not to increase dosage without consulting their prescriber. So, routes and dosages. Again, the oral dosing is generally reserved for patients with chronic severe pain, such as that associated with cancer. Because oral morphine undergoes extensive metabolism on its first pass through the liver, Oral doses are usually higher than the parenteral doses. A typical dosage is 10 to 30 milligrams, repeated every 4 hours as needed. However, oral dosing is highly individualized, and some patients may require 75 milligrams or more. The controlled release formulations may be administered every 8 to 12 hours, and the extended release formulation is given every 12 to 24 hours. Patients should be instructed to swallow these products intact without crushing or chewing. Again, also warn patients who are using the extended release formula or the combo drugs not to drink alcohol, which again can accelerate the release of morphine from these medications. Which brings us to other strong opioid agonists. In an effort to produce a strong analgesic with a low potential for respiratory depression and abuse, pharmaceutical scientists have created many new opioid analgesics. However, none of the newer pure opioid agonists can be considered truly superior to morphine. These drugs are essentially equal to morphine with respect to analgesic action, abuse liability, and the ability to cause a respiratory depression. Also, to varying degrees, they all can cause sedation, euphoria, constipation, urinary retention, cough suppression, hypotension, and meiosis. However, despite their similarities to morphine, the newer drugs do have unique qualities. Therefore, one agent may be more desirable than another in a particular clinical setting. With all of the newer pure opioid agonists, toxicity can be reversed with an opioid antagonist. Again, Narcan. It's important. Differences between morphine and the newer strong opioid analgesics will be discussed here in the following table, which shows the dosage, route, and time courses for morphine and the newer drugs. So again, here's an excellent spot to hit pause so you can see the clinical pharmacology of pure opioid agonists. So we can kind of touch base on the first, which is fentanyl. Fentanyl is a strong opioid analgesic with a high milligram potency. 8 formulations are available for administration by 4 different routes: parenteral, transdermal, transmucosal, and intranasal. Depending on the route, fentanyl may be used for surgical analgesia, chronic pain control, and control of breakthrough pain in patients taking other opioids. All preparations are regulated under Schedule II of the Controlled Substance Act. Fentanyl, regardless of route, has the same adverse effects as other opioids: respiratory depression, sedation, constipation, urinary retention, and nausea. Of all of these, respiratory depression is the greatest concern. Signs of toxicity can be reversed with an opioid antagonist. Again, Narcan. Fentanyl, regardless of route, has the same adverse effects. Fentanyl is metabolized by CYP3A4, and therefore fentanyl levels can be increased by other CYP3A4 inhibitors. Patients who are taking these inhibitors should be closely monitored for severe respiratory depression and other signs of toxicity. Transdermal. Fentanyl transdermal system consists of a fentanyl-containing patch that is applied to the skin of the upper torso. The drug is slowly released from the patch and absorbed through the skin, reaching effective levels in 24 hours. Levels usually remain steady for another 48 hours, after which the patch should be replaced. If a new patch is not applied, effects will nonetheless persist for several hours, owing to the continued absorption of residual fentanyl remaining on the skin. Transdermal fentanyl is indicated only for persistent severe pain in patients who are already opioid tolerant. Use in non-tolerant patients can cause fatal respiratory depression. The patch should not be used in children younger than 2 years or in anyone younger than 18 who weighs less than 110 pounds. Also, the patch should not be used for post-operative pain, intermittent pain, or pain that responds to a less powerful analgesics. Like other strong opioids, fentanyl overdose poses a risk for fatal respiratory depression. If respiratory depression develops, it may persist for hours after the patch is removed, owing to the continued absorption of fentanyl from the skin. Fentanyl patches are available in several strengths, which deliver fentanyl to the systemic circulation. The smallest effective patch should be used. If a dosage starts to become greater than 100 micrograms per hour and is required, a combination of patches may be applied. After placing a fentanyl patch, it must not be exposed to direct heat, so heating pads, hot baths, or electric blankets, because doing so can accelerate fentanyl's release, and as can fever, sunbathing, and strenuous exercise. Because analgesic effects can take up to 24 hours to develop, your as-needed therapy with a short-acting opioid may be required until the patch takes effect. As with other long-acting opioids, if breakthrough pain occurs, supplement dosing with a short-acting opioid is indicated. For most patients, patches can be replaced every 72 hours, although some may require a new patch in 48. Used or damaged patches should be folded in half with the medication side touching and flushed down the toilet. Unused patches should be stored out of reach of children. Which brings us to the transmucosal dose. Fentanyl's transmucosal administration is available in 4 formulations: lozenges, buccal tablets, sublingual spray, and sublingual tablets. All 5 products are approved only for breakthrough cancer pain in patients at least 18 years or older who are already taking opioids around the clock and have developed some degree of tolerance. Defined as needing, for 1 week or longer, at least 60 milligrams of oral morphine a day, or 30 milligrams of oral oxycodone a day, or 25 milligrams of oral oxymorphone a day, or 8 milligrams of oral hydromorphone a day, or 25 micrograms of fentanyl per hour, or an equine analgesic dose of another opioid. So there is quite the regulation on that. Transmucosal fentanyl must not be used for acute pain, post-operative pain, headaches, or athletic injuries. Furthermore, it's essential to appreciate that the dose of fentanyl in these formulations is sufficient to kill non-tolerant individuals, especially the young and children. Accordingly, these products must be stored in a secure child-resistant location. All fentanyl transmucosal formulations are regulated as Schedule II products. Owing to risks of misuse, abuse, and overdose, all transmucosal fentanyl products are available only through a restricted distribution program called the Transmucosal Immediate Release Fentanyl Risk Evaluation and Mitigation Strategy Access Program. The patient must enroll in this program to receive the product, and they are available only through pharmacies that are enrolled in these programs. Adverse effects of transmucosal fentanyl are like those of other opioid preparations. Again, the most common would be dizziness, anxiety, confusion, nausea, vomiting, constipation, dyspnea, weakness, and headaches. The biggest concerns again is your respiratory depression and potential shock. Because of differences in bioavailability, transmucosal fentanyl products are not interchangeable on a microgram for microgram basis. So 100 micrograms of a buccal tablet produces about the same effect on the fentanyl blood level as a 200 microgram lozenge. So if a patient does switch from one transmucosal product to another, dosages of the new product must be titrated to determine a strength that is safe and effective. Lozenge on a stick. Your fentanyl lozenge on a stick, also known as the oral transmucosal fentanyl citrate, consists of a raspberry-flavored lozenge on a plastic handle that looks much like a lollipop. To administer the unit, patient places it between the cheek and the lower gum and actively sucks it. Periodically, the unit should be moved from one side of the mouth to the other. The consumption of the entire lozenge takes about 15 minutes, as the patient sucks some of the drug is absorbed directly and rapidly through the oral mucosa, and some is swallowed and absorbed slowly through the GI tract. Analgesia usually begins in 10 to 15 minutes and peaks in about 20 minutes and persists for about 1 to 2 hours. Dosing should begin with a 200 microgram unit. If breakthrough pain persists, the patient may take another 200 microgram unit 15 minutes after finishing the first one. Unit size should be gradually increased until an effective dose is determined. If the patient, however, needs more than 4 units per day, it may be time to give a higher dose of his or her long-acting opioid. To promote safe and effective use of the medication, the manufacturer provides an ACTAKE welcome kit as well as a child safety kit with the initial drug supply. The kit contains educational material and safe storage containers for the unused, partially used, and completely used units. Which brings us to the buccal tablet. Fentanyl buccal tablets are available in several strengths. Patients should place the tablets above the rear molar between the cheek and the gum and let it dissolve in place, which usually takes 15 to 30 minutes. Remaining fragments should be swallowed with a glass of water. Patients should not split, chew, suck, or swallow the tablet. The initial dose is 100 micrograms, and if the 100 micrograms is inadequate, another 100 micrograms can be given after 30 minutes. During each subsequent episode, dosage may gradually increase, and again if needed, until an effective dose is established. The sublingual spray. Fentanyl sublingual spray is available again in several dosages. Individual doses of sus, which is the sublingual spray, are supplied in single-use spray units. After the medication is dispensed under the tongue, the spray must be disposed of in a disposal bag provided by the manufacturer. The initial dose should be 100 micrograms. If pain is not relieved by 30 minutes after the first dose, one additional dose may be administered. Use should be very limited and to 4 doses per day. Which brings us to the sublingual tablet. Fentanyl sublingual tablet are available in 6 strengths. Each strength is different color and shape. Patients should place the tablet on the floor of the mouth directly under the tongue and allow it to dissolve completely. If the mouth is dry, it should be moistened with water before dosing. Tablets must not be chewed, sucked, or swallowed. Patients should not eat or drink until the tablet is gone. Again, initial dosing is 100 micrograms, and if it is inadequate, another 100 micrograms can be taken in 30 minutes. No more than 2 doses should be used for any pain episode, and patients should wait at least 2 hours before dosing again. With each subsequent episode, the dose should be titrated until a safe and effective dose has been identified. Which brings us to the intranasal spray, also known as Lozanda, which is much like the transmucosal fentanyl. Lozanda is indicated only for breakthrough cancer pain in a patient who at least 18 years of age who already is taking opioids around the clock and has developed some degree of tolerance. The spray must not be used for acute pain, post-op pain, headaches, or athletic injuries. Because of the difference in bioavailability, Lozanda is not interchangeable with other fentanyl products on a microgram for microgram basis. Adverse effects are like those of other opioid preparations. Again, the big concern is respiratory depression and shock. As with the transmucosal product, the dose of fentanyl in Lozanda can be fatal to a non-tolerant individual, so the spray must be stored in a secure, child-resistant location. That intranasal fentanyl is supplied in a 5 milliliter bottle that have a metered dose nasal spray pump. Each bottle contains enough solution for 8 sprays. Two strengths are available, and the dosing usually starts again with 100 micrograms. And if needed, dosage can be titrated upward at subsequent pain episodes, as follows. Patients should allow at least 2 hours between dosing. If more than 5 days elapse since the last dose, the bottle should be discarded and replaced with a new one. Which brings us to its black box warning. Products containing fentanyl can cause fatal respiratory depression. Many of these products are only available through a restricted distribution program, secondary to the misuse and its abuse. Which brings us to meperidine, or Demerol, which shares the major pharmacologic property of morphine. With oral administration, analgesia is strong. Meperidine was once considered a first-line drug for relief of moderate to severe pain. Now, the use of meperidine has declined significantly for a couple reasons. The first, the drug has a short half-life, so dosing must be repeated at short intervals. Second, meperidine interacts adversely with a number of drugs. Third, with continued use, there is a risk for harm owing to accumulation of toxic metabolites. Accordingly, routine use of the drug should be avoided. However, meperidine may still be appropriate for a patient who can't take other opioids and for patients with drug-induced rigors or post-anesthesia shivers. Meperidine can interact with a monoamine oxidase inhibitor, or MAOI, to cause excitation, delirium, hyperpyrexia, and convulsions. Coma and death can follow. The underlying mechanism appears to be excessive activation of the serotonin receptors, owing to meperidine-induced blockade of serotonin reuptake. Clearly, the combination of meperidine with a MAOI should be avoided. Other drugs that increase serotonin availability may also pose a risk. Repeated dosing results in accumulation of normeperidine, a toxic metabolite that can cause dysphoria, irritability, tremors, and seizures. To avoid toxicity, treatment should not exceed 48 hours, and the dosage should not exceed 600 milligrams in 24 hours. Meperidine is available in several tablet dosing, as well as a syrup for oral use and in a solution for IV use, as well as intramuscular and subcutaneous. The usual adult dosage is 50 to 150 milligrams, repeated every 3 to 4 hours as needed, up to a maximum of 600 milligrams per day. For children, it is usually 1 to 1.8 milligrams per kilogram that can be repeated every 3 to 4 hours. Again, as noted, prolonged use must be avoided. Which brings us to a classic, methadone. Methadone has pharmacologic properties again similar to that of morphine. The drug is effective orally and has a long duration of action. Repeated dosing can result in accumulation. Methadone used to relieve pain and to treat opioid addiction. The use of methadone for pain control has risen dramatically. The use of methadone in drug abuse treatment programs will be discussed in more detail in Chapter 33. Because methadone can cause a QT prolongation, all patients who receive an electrocardiogram EKG before treatment, 30 days later, and annually thereafter. If QT intervals exceed more than 500 mSecs, stopping methadone or reducing the dosage should be considered. Which leads us to our patient education on methadone toxicity. To reduce the risk of methadone toxicity, patients should be warned against taking more methadone than was prescribed and should be cautioned to avoid other CNS depressants. Again, the benzodiazepines, alcohol, and other opioids. Methadone is supplied in either immediate release tablets and in a solution for oral use, and in solution for IM or sub-Q injection. In addition, the drug is available in dispensable 40 milligram tablets for detoxification and maintenance of opioid addicts. Initial oral analgesic doses For adults range from 2.5 to 20 milligrams, which can be repeated every 8 to 12 hours as needed, leading us to another black box warning. Again, methadone prolongs that QT interval and therefore poses a risk for potential fatal dysrhythmias. Tirzepatide has developed in patients taking 65 milligrams to 400 milligrams per day. To reduce that risk, methadone should be used with great caution, if at all, in a patient with an existing QT prolongation or a family history of a long QT syndrome, and in those taking other QT prolongation drugs. In addition, methadone causes severe respiratory depression that can be potentially fatal. Which brings us to hydromorphone, oxymorphone, and levorphanol. So, the basic pharmacology on these three drugs are strong opioid agonists with pharmacologic actions like those of morphine, and all three are indicated for the moderate to severe pain. Dosages and time courses are shown again in Table 22.4. Adverse effects include the classic respiratory depression, sedation, cough suppression, constipation, urinary retention, nausea, and vomiting. Of note, hydromorphone may cause less nausea than morphine. Toxicity can be reversed with Narcan, and all three drugs are considered Schedule II agents. So the black box warning, therefore, on hydromorphone and oxymorphone. Both have high abuse potential and can cause fatal respiratory depression, especially when combined with other sedating agents, which include alcohol. Long-acting forms of oxymorphone should be prescribed only by a provider with additional education regarding chronic pain. So, let's talk about the preparation, dosage, and administration. Hydromorphone, or Dilaudid, is available in 6 formulations. Again, our immediate release tablet, extended release tablet, oral liquid, and rectal suppositories. With the immediate release tablet, the usual adult dose is 2 milligrams every 4 to 6 hours. With the extended release tablets, the dosage is based on how much opioid was being used before switching to the extended release. With the oral liquid, again, the adult dose is 2.5 to 10 milligrams every 3 to 6 hours. And rectal suppositories, the usual dose is 3 milligrams every 6 to 8 hours. Which brings us to oxymorphone. Oxymorphone is available in 3 formulas. Again, our immediate release tablet and extended release tablet. All oxymorphone tablets should be taken on an empty stomach because dosing with food can produce excessive peak levels. Also, alcohol should be avoided because it can increase blood levels of oral oxymorphone. For oral therapy in opioid-naive patients, the usual initial dosage is 10 to 20 milligrams every 4 to 6 hours, using immediate release tablets, or 5 milligrams every 12 hours, using extended release. Which brings us to the last one, levorphanol. Levorphanol is available in 2 milligram oral tablets. The usual adult dosage is 2 milligrams repeated every 6 to 8 hours as needed. Which takes us now to moderate to strong opioid agonists. The moderate to strong opioid agonist is similar to morphine in most respects. Similar to morphine, these drugs produce analgesia, sedation, and euphoria. In addition, they can cause respiratory depression, constipation, urinary retention, cough suppression, and meiosis. The differences between these moderate to strong opioids and morphine are primarily quantitative. The moderate to strong opioids produce less analgesia and respiratory depression than morphine and have a somewhat lower potential for abuse. Similar with morphine, toxicity from the moderate to strong agonists again will be reversed with Narcan. Which brings us to codeine. Codeine is indicated for relief of mild to moderate pain. The drug is usually administered orally. Side effects are dose limiting, and as a result, although taking codeine can produce significant pain relief, the degree of pain relief that can be achieved safely is considered quite low, much lower than with morphine. When taken at usual analgesic dose, codeine produces about as much pain relief as 325 milligrams of aspirin or 325 milligrams of Tylenol. For analgesic use, codeine is formulated alone and in combination with non-opioid analgesics. Because codeine and non-opioid analgesics relieve pain by different mechanisms, the combinations can produce greater pain relief than either agent alone. Codeine alone is classified under a Schedule II of the Controlled Substance Act. The combination preparations are classified under Schedule III. Although codeine is classified along with morphine in Schedule II, the abuse liability of codeine appears to be significantly lower. Codeine is an extremely effective cough suppressant and is widely used for exactly that action. The antitussive dose, of 10 milligrams or lower than analgesic doses. Codeine is formulated in combination with various agents to suppress the cough. These mixtures are classified under Schedule 5. So, the black box warning then on codeine. In the liver, 10% of each dose of codeine undergoes conversion to morphine, the active form of codeine. The enzyme responsible is CYP2D6. Among the ultra-rapid metabolizers, who carry multiple copies of CYP2D6 gene, codeine is usually effective and has led to death in some children. Severe toxicity can develop in breastfed infants whose mothers are taking codeine. The cause is high levels of morphine in breast milk, owing to the ultra-rapid codeine metabolism. So, preparation, dosage, and administration. Codeine is available in tablets and in solution. The usual analgesic dosage for an adult is 15 to 60 milligrams every 3 to 6 hours. The usual analgesic dosage for children 1 year and older is half a milligram per kilo every 4 to 6 hours. Oxycodone has analgesic actions equivalent to those of codeine. Administration is oral and is available in immediate release tablets, capsules, controlled release tablets, and oral solutions. In addition, the drug is available in combination with aspirin, Tylenol, and ibuprofen. All formulas are classified under Schedule II. Here's an excellent spot to hit pause so you can see all the different dosages possible. It also comes with a black box warning. Oxycodone, like oxymorphone or hydromorphone, has a potential for abuse and can cause fatal respiratory depression. Long-acting forms of oxycodone should be prescribed only by providers with additional education regarding chronic pain. Oxycodone is metabolized by CYP3A4, so drugs that inhibit or induce CYP3A4 can alter oxycodone levels. Specifically, drugs that induce CYP3A4 can lower oxycodone levels and thereby compromise pain relief. Conversely, drugs that inhibit can raise oxycodone's level and thereby pose a risk for toxicity. The controlled release oxycodone, or OxyContin, is a long-acting analgesic designed to relieve moderate to severe pain around the clock for an extended time. Dosing is done every 12 hours, not as needed. And if breakthrough pain occurs, supplemental dosing with a short-acting analgesic is recommended. Owing to the increased reports of OxyContin abuse, safety warnings have been strengthened, and in 2010, the product was reformulated. The new formulation bears the imprint OP, the old formulation bears the imprint OC. Reformulation occurs because abusers could crush the OxyContin tablets and then snort the resulting powder or dissolve the powder in water and inject it IV. Both practices allowed immediate absorption of the entire dose and therefore produced blood levels that were much higher than those produced when the tablet was ingested whole and absorbed gradually. The result was an intense high coupled with a risk factor for fetal respiratory depression. Compared with the old tablets, OxyContin OP tablets are much harder to crush into a powder, and if exposed to water or alcohol, the tablet forms a thick gel, rather than a solution that can be drawn into a syringe and injected. To minimize the risk, patients should swallow the tablets whole without breaking, crushing, or chewing. Furthermore, the 80 milligram formulation must be reserved for patients who are already opioid tolerant. As with all opioids, concerning about abuse and addiction should not interfere with using OxyContin to manage pain. Rather, the drug must simply be prescribed appropriately and then used as prescribed. A new formulation of oxycodone agonists paired with Narcan, marketed as Targinic ER, was approved in 2014 for the treatment of chronic pain. Because the medication contained Narcan, an opioid antagonist, patients are deterred from abusing the drug because crushing the tablet will cause symptoms of opioid withdrawal. As with other long-acting opioids, the medicine can cause fatal respiratory depression, and again should only be prescribed by a provider with additional education regarding chronic pain. Leading us to hydrocodone. Hydrocodone has analgesic actions equivalent to those of codeine. The drug is taken orally to relieve pain and to suppress the cough. The usual dosage of immediate release is 5 milligrams. New extended release products contain only hydrocodone and can be taken every 12 to 24 hours. Immediate release hydrocodone is combined with Tylenol or ibuprofen. For cough suppression, the drug is combined with an antihistamine and nasal decongestant. All of these products are currently classified under Schedule II. So, trade names for the combo products containing hydrocodone include Vicodin, Vicoprofen, and Lortab. So, it's black box warning. Hydrocodone. All forms of hydrocodone contain a black box warning. Products that contain Tylenol are associated with hepatotoxicity, and extended release forms of hydrocodone can cause fatal respiratory depression and should only be prescribed by a provider with additional education regarding chronic pain. Which takes us to the next medication, tapentadol. Tapentadol, also known as Nucynta, is indicated for oral therapy of moderate to severe pain, acute or chronic, in patients 18 or older. Analgesic effects are equivalent to those of oxycodone, and like other opioids, the medicine can cause CNS depression and respiratory depression and has a significant potential for abuse. However, the drug differs from the opioids in two important ways. First, in addition to activating the mu receptor, opioid receptors, it also blocks the reuptake of norepinephrine, similar to tramadol. Secondly, it also causes less constipation than traditional opioids. So, its pharmacokinetics. Tapentadol is administered orally, and the plasma level peaks usually in 1.5 hours after drug dosing. Because of extensive first-pass metabolism, the bioavailability is only 32%. The drug is eliminated primarily by the renal excretion. Its half-life is about 4 hours. Its adverse effects. Again, the most common adverse effects would be nausea, vomiting, headache, dizziness, and drowsiness. And like other opioids, it can cause respiratory depression, so it should be avoided in patients with pre-existing respiratory depression or in those with acute or severe asthma. Again, as noted, the drug causes less constipation than other opioids. Nonetheless, it is contraindicated with patients who have a paralytic ileus. As discussed later, tramadol, a drug similar to tapentadol, poses a risk for seizures. To date, seizures have not been reported with tapentadol. Nonetheless, caution should be exercised in patients who have a history of seizure disorder. Owing to its potential drug abuse, it is classified Schedule II. Patients should be monitored for abuse and addiction, and tapentadol is classified in the FDA pregnancy risk as a Category C, indicating that no adequate studies in pregnant patients have been performed. So, drug interactions. The depressant effects of tapentadol can add to those of other agents and can thereby increase the risk for respiratory depression, sedation, and even coma. Because tapentadol can increase serum levels of norepinephrine, combining use with a MAUI might result in a hypertensive crisis, which we'll discuss more in Chapter 25. Accordingly, tapentadol should not be used within 14 days of taking a MAUI. Your package labeling says that a life-threatening serotonin syndrome may result from combining tapentadol with an SSRI, a serotonin or norepinephrine reuptake inhibitor, a tricyclic antidepressant, or a serotonin agonist. However, in clinical trials, combined use with an SSRI had no ill effects. Again, tapentadol neither inhibits nor induces P450 enzymes, and therefore clinically relevant interactions involving the cytochrome P450 system was seen unlikely. Its preparation, dosage, and administration. Tapentadol is available in two formulas, your immediate release and extended release. The immediate release are indicated for moderate to severe acute pain. The extended release are indicated for only moderate to severe chronic pain, and then only in patients who require continuous around-the-clock treatment with an opioid. Your dosaging is as follows. Again, here's an excellent spot to hit pause if you're unfamiliar with different medications and their dosages. One thing that I will state though is in patients that have severe hepatic or renal impairment, the medication should not be used. Which brings us now to agonist antagonist opioids. So, compared with pure opioid agonists, the agonist antagonist have a low potential for abuse. Again, they produce a less respiratory depression and generally have less powerful analgesic effects. When given to a patient who is physically dependent on pure opioid agonists, these drugs can precipitate withdrawal. The clinical pharmacology of an agonist-antagonist is shown here in Table 22.5, which is a good spot to hit pause if you're unfamiliar. So, the first medication we'll talk about will be pentazocine. Pentazocine, also known as Talvin, was the first agonist-antagonist opioid available and can be considered, I guess, as the prototype for this group. The drug is indicated for mild to moderate pain. Talvin is much less effective than morphine because against severe pain. Talvin acts as an agonist at kappa receptors and as an antagonist at mu receptors. By activating the kappa receptors, the drug produces analgesia, sedation, and respiratory depression. However, unlike the respiratory depression caused by morphine, respiratory depression caused by Talvin is very limited. Beyond a certain dose, no further depression can occur. Because it lacks agonist action at the mu receptors, Talvin produces little or no euphoria. In fact, at a supratherapeutic dose, Talvin produces unpleasant reactions, your anxiety, strange thoughts, nightmares, and hallucinations. These psychotomimetic effects may result from activation of kappa receptors. Because of its subjective effects, Talvin has a low potential for abuse and is classified between a Schedule II and a Schedule IV, depending on the state regulation. When administered to a patient who is physically dependent on a pure opioid agonist, Talvin can precipitate withdrawal. Recall that the mu receptors mediate physical dependence on pure opioid agonists, and that Talvin acts as an antagonist at these receptors. By blocking access of the pure agonist to mu receptors, Talvin will prevent receptor activation, therefore triggering withdrawal. Talvin and other drugs that block mu receptors should never be administered to a person who is physically dependent on a pure opioid agonist. If Talvin-like agents are used, the pure opioid agonist must be withdrawn first. Which brings us to the physical dependence which can occur with Talvin, but symptoms of withdrawal are generally mild, usually cramps, fever, anxiety, and restlessness. Treatment is relatively rare and it's rarely required. As with the pure opioid agonist, toxicity from Talvin will be reversed with Narcan. So, its preparation, dosage, and administration. Talvin is available in a combination with Narcan for oral therapy and is available as a combo drug called Talvin NX. The usual dosage is 1 tablet every 3 to 4 hours, but may be increased to 2 tablets every 3 to 4 hours for a daily maximum of 12 tablets, which would equate to 600 milligrams. It's usually 50 milligrams per tablet. Which brings us to the next medication. Butorphanol, also known as Stadol, has actions similar to those of pentazocine or Talvin. The drug is an agonist at kappa receptors and an antagonist at mu receptors. Its analgesic effects are less effective than that of morphine. As with Talvin, there is a ceiling to respiratory depression. Again, the drug can cause psychotomimetic reactions, but again, these are considered rare. Butorphanol, however, increases cardiac work and should not be given with patients who have a history of a myocardial infarction. Physical dependence can occur, but symptoms of withdrawal are relatively mild. The drug may induce a withdrawal reaction in patients who are physically dependent on a pure opioid agonist. Due to that, it has a low potential for abuse and is regulated as a Schedule IV substance. Toxicity will be reversed with Narcan. It can be administered via a nasal spray, and the dosage is usually 1 milligram per spray, which can be repeated every 60 to 90 minutes as needed. The two-dose sequence may then be repeated every 3 to 4 hours. Which brings us to buprenorphine. Buprenorphine, also known as Suboxone, differs significantly from other opioid agonist-antagonist. The drug is a partial agonist at mu receptors and an antagonist at kappa receptors. Analgesic effects are like those of morphine, but significant tolerance has not been observed. Although Suboxone can depress respirations, severe respiratory depression has not been reported. So similar to Talvin, Suboxone can precipitate a withdrawal reaction in persons physically dependent on a pure opioid agonist. Physical dependence of Suboxone develops, but symptoms or abstinence are delayed. Peak responses may not occur until 2 weeks after the final dose was taken. Although pretreatment with Narcan can prevent toxicity from Suboxone, Narcan cannot readily reverse toxicity that has already developed. Suboxone is considered a classified Schedule III substance. In addition to its use for analgesia, Suboxone is used to treat opioid addiction, which again we'll discuss further in Chapter 33. Suboxone also prolongs a QT interval, so it's posing a risk for potentially fatal dysrhythmias. So again, anyone with a family history or already has a prolonged QT syndrome may not tolerate this medication well. The risk for adverse effects may be increased by coexisting conditions. Again, these may include psychosis, alcoholism, adrenal cortical insufficiency, and severe liver or renal impairment. It's prepared in 5 formulas, 4 of which are discussed here: a transdermal patch, a buccal film, a sublingual tablet, and a sublingual film. The patch and buccal film are approved for pain management. The sublingual products are approved only for opioid addiction, but are used off-label for pain management. So if you're talking about the transdermal patch, it is indicated for moderate to severe chronic pain in patients who need continuous analgesia for an extended time. The patch is applied once every 7 days. It has several different dosing. Again, the low strength is used for opioid naive patients or for those using an opioid in a low dosage. Dosage may be titrated to a higher strength after a minimum of 72 hours. And breakthrough pain can be managed with Tylenol and a nonsteroidal anti-inflammatory drug, or a short-acting opioid. Patches are applied to 8 different sites. It can be your upper outer arm, upper front of chest, upper side of chest, upper back, and that can be on either side, left or right. Sites should be rotated when a new patch is applied. No site should be reused within 21 days. The site should be hairless or nearly so. If needed, hair can be removed by clipping or shaving. The site may be cleaned, but only with water, no soaps, alcohol, or abrasives. No lotion or oil should be applied. Patches should not be cut or exposed to heat. Again, heating pads, hot baths, saunas, heat lamps, extended sunshine will cause the medication to work faster than it should. Keep in mind, if a patch use is stopped, opioids should not be given for at least 24 hours. Which brings us to the sublingual tablet and film. Again, Suboxone is available in 3 sublingual formulas, which is a tablet, which contains Suboxone alone, or 2 other formulations in tablets and films. Again, that's marked as Suboxone. All 3 formulations are approved only for the management of opioid addiction. However, they are also used off-label for analgesia. For opioid addiction, dosing is done once a day. For pain management, dosing is done 3 to 4 times a day. The use of these sublingual products is restricted in the US. To prescribe Suboxone or Subutex, a provider must undergo training and register for appropriate access. The use of these products for opioid addiction is discussed in further detail in Chapter 40. A new form of Suboxone by the name of Belbuca was approved in 2015 for the management of chronic pain. The film is applied to the inside of the cheek every 12 hours. Because it is used to treat or for the treatment of around-the-clock chronic pain, it has the potential to cause life-threatening respiratory depression. Belbuca should only be prescribed by, again, a provider who has additional education in chronic pain. So, that brings us to prescribing opioids for chronic non-cancer pain. The amount of prescriptions opioids has risen steeply since the 1990s. Efforts to improve pain management has led to a tenfold increase in opioid prescriptions, accompanied by a substantial increase in abuse, serious injuries, and deaths. In 2013, accidental overdoses with a prescription opioid resulted in 16,235 fatalities. In patients with chronic pain of a non-malignant origin, opioids can reduce discomfort, improve mood, and enhance function. Accordingly, pain experts now recommend that opioids not be withheld from people with chronic pain. Nonetheless, because of the concern about addiction, tolerance, adverse effects, diversion to street use, and regulatory action, physicians, PAs, and NPs are often reluctant to prescribe these medicines. To some degree, all of these concerns are legitimate. However, patients still have a right to effective treatment. Therefore, there is a need to balance patients' right with prescribers' concerns. Before the creation of the CDC pain guideline in 2016, the American Academy of Pain Management and the American Pain Society issued guidelines for using opioids for a patient that has chronic non-cancer pain. These provisions included using opioids only after a non-opioid analgesic or more conservative method has failed, discussion with the benefits and risks for long-term opioids with the patient, when possible, only using one prescriber and one pharmacy, ensuring comprehensive follow-up to assess efficacy and side effects of treatment, and to monitor for signs of opioid abuse. Stopping opioids after an attempt at opioid rotation has produced an adequate benefit, and finally, fully documenting the entire process. So here's the CDC's guideline for safe opioid prescription. I'll let you hit pause so you can review this yourself. It's quite a bit. So I'll make sure we keep this in spots where it makes most sense. So there was a couple different spots where you need to, kind of read this over. So the clinical use of opioids, prescribing guidelines for pain assessment. Assessment is an essential component of pain management. Pain and current functional status should be evaluated at every patient appointment. Assessment should include documentation of where the pain is located, what type of pain is present, how the pain changes with time, what makes the pain better, what makes it worse, and how much the pain impairs the patient's ability to function. In addition, you should assess for psychological factors that can reduce pain thresholds, which would include anxiety, depression, fear, and anger. The patient's education. It's crucial that the patient understands the risk and the benefit of using opioids to treat chronic non-cancer pain. The provider should discuss goals of care regarding pain and function. Treatment goals set by the patient and provider should be realistic. These goals should be revisited at each patient appointment. If the risk begins to outweigh the benefit of opioid therapy, a new plan should be developed. Initiating therapy, non-pharmacologic therapy, and non-opioid therapy should be used to treat chronic pain before opioid therapy. If these modalities are not successful in improving patient pain and function, opioid therapy can be considered. Although research is lacking regarding the safest way to initiate outpatient therapy in the patient with chronic pain, there is a small amount of evidence to suggest that starting patients on extended release or long acting medications before starting them with an immediate release medication may lead to an increase in medication overdose. Therefore, current recommendations suggest initiating therapy with immediate release medications first. In addition, the use of non-opioid adjuvant medications should be continued to maximize pain control and patient function. The CDC has concluded a checklist for providers, and there is a website listed here. Dosage determination. Providers should always start with the lowest effective dosage for a patient. Standard doses cannot be relied on as appropriate for all patients. For example, if a standard 10 mg dose of morphine were employed for all adults, only 70% would receive adequate relief. The other 30% would be undertreated. Not all patients have the same tolerance for pain, and therefore some need larger doses than others for the same disorder. Some conditions hurt more than others. Older adult patients metabolize opiates slowly and therefore require a lower dose than a younger adult. Because the blood-brain barrier of newborns is poorly developed, these patients are especially sensitive to opioids. Therefore, they generally require a smaller dose than do in older infants and young children. Again, to minimize the physical dependence and abuse, opioid analgesics should be administered in the lowest effective dosage for the shortest time needed. Be aware, however, that larger doses are needed for patients who have more intense pain and for those who have developed tolerance. As pain diminishes, opioid dosage should be reduced. As soon as possible, the patient should be able to switch to a non-opioid analgesic, such as aspirin or Tylenol. Avoiding a withdrawal reaction. When opioids are administered in high doses for 20 days or longer, clinical significant physical dependence starts to develop. Under those conditions, abrupt withdrawal will precipitate an abstinence syndrome, To minimize symptoms of abstinence, opioids should be withdrawn slowly, tapering the dosage over 3 days. If the degree of dependence is especially high, as can occur in opioid addicts, dosage should be tapered over 7 to 10 days. So, physical dependence, abuse, and addiction as clinical concerns. The objective of the following discussion is to dispel concerns about the dependence, abuse, and addiction in the medical patient so that these concerns do not result in under-medication and needless suffering. So, per the definition, before we can discuss the clinical implication of physical dependence, abuse, and addiction, we need to define the term. Physical dependence, as noted, is a state in which an abstinence syndrome will occur if the dependence-producing drug is abruptly withdrawn. Physical dependence is not the same as addiction. Abuse can be broadly defined as a drug use that is inconsistent with medical or social norms. By this definition, abuse is determined primarily by the reason for drug use and by the setting in which the use is occurring, and not by the pharmacologic property of the drug itself. An example of this is whereas it is not considered abuse is to administer 20 milligrams of morphine in a hospital to relieve pain. It is considered abuse to administer the same dose of the same drug on the street to produce euphoria. This concept is discussed further in Chapter 30. Addiction. Addiction is defined by the American Society of Addiction Medicine as a disease process created by continued use of a psychoactive substance despite physical, psychological, or social harm. Note that somewhere in this definition is addiction equated by physical dependence. In fact, physical dependence is not even part of the definition. The concept of addiction will be discussed further in Chapter 30, so we'll breeze kind of over that for the time being. Balancing the need to provide pain relief with the desire to minimize abuse. Although concerns of opioid abuse in the clinical setting are small, they cannot be dismissed entirely. You're still obligated to administer opioids with discretion in an effort to minimize abuse. The first step is to identify patients at risk for abuse by using a screening tool, such as the NIDA Modified Assist, which is available on drugabuse.gov. When non-abusers say they need more pain relief, believe them and provide it. In contrast, when a likely abuser is requesting more analgesic, some healthy skepticism is in order. When there is doubt as to whether a patient is abuse-prone or not, logic dictates giving the patient the benefit of the doubt and providing the medication. The second step is to become familiar with the State Prescription Drug Monitoring Program. This database contains information regarding all scheduled medications prescribed to a patient, including who prescribed them and the amount prescribed. Providers should carefully review the patient's history with controlled substances and check the PDMP, both at initiation of opioid therapy as well as periodically during the course of treatment. The evaluation of the database allows providers to assess for medication combinations that may promote dangerous side effects. Finally, the provider should consider obtaining a urine drug test for controlled substances, including illicit drugs, before initiation of therapy and at least annually after that. Patients taking multiple medications include those like benzodiazepines, other opioids, or heroin, may be at increased risk for fatal overdose. Providers that receive unexpected results can use this opportunity to educate the patient and change the patient's treatment plan. REMS to reduce opioid-related morbidity, mortality, and abuse. The FDA introduced a new risk evaluation and mitigation strategy for extended release and long-acting prescription opioids. The objective is to reduce injuries and death from prescription opioids and to reduce abuse. The central component is education for prescribers and patients. Training for prescribers focuses on the patient selection, balancing the risk and benefit of opioids, monitoring treatment, and recognizing opioid misuse, abuse, and addiction. In addition, prescribers are taught how to counsel patients on the safe use of opioids and are given written instructions for their patients. When patients have a prescription filled, the pharmacy provides a medication guide. The REMS program does have limitations, however. For instance, the prescriber's participation is voluntary and not mandatory. Prescribers who choose not to accept training may do so. Second, the REMS program does not apply to all opioids. There are exceptions of your transmucosal fentanyl and sublingual Suboxone. Your immediate release products are largely exempt because they are considered safer than the long-acting extended release products. Yes, immediate release products can cause death. However, the risk is much higher with long-acting and extended release products because the dose of opioid is much greater than it is in the immediate release product. Products currently covered by the REMS include the following list. So I'll let you hit pause so you can kind of look at them all. It's somewhat extensive, but not overwhelmingly so. That brings us to our cancer-related pain. Treating chronic pain of cancer differs substantially from treating acute pain of other disorders. When treating cancer pain, the objective is to maximize comfort. Psychological and physical dependence are minimal concerns. Patients should be given as much medication as needed to relieve pain. In the words of one pain specialist, no patient should wish for death because of the physician's reluctance to use adequate amounts of opioids. With proper therapy, cancer pain can be effectively managed in about 90% of patients. Cancer pain will be discussed in more detail in Chapter 83. So here is another spot to hit pause where you will see the patient-centered care across the lifespan on opioid analgesics. Are opioid antagonists. Opioid antagonists are drugs that block the effects of opioid agonists. Principal uses are treatment of opioid overdoses, relief of opioid-induced constipation, reversal of postoperative opioid effects, and the management of opioid addiction. 4 pure antagonists are available, and 3 will be discussed. Narcan, methylene altrexone or Relistor, and naltrexone or Revia. Narcan, which is the bread and butter in pretty much all of America at this time. How does it work? Well, it is a structural analog of morphine that acts as a competitive antagonist at opioid receptors, thereby blocking opioid action. Narcan can reverse most effects of the opioid agonists, including the respiratory depression, coma, and analgesia. When administered in the absence of opioids, Narcan has no significant effect. If administered before giving an opioid, Narcan will block opioid action. If administered to a patient who is already receiving opioids, Narcan will reverse analgesia, sedation, euphoria, and respiratory depression. If administered to an individual who is physically dependent on an opioid, Narcan will precipitate an immediate withdrawal reaction. Narcan was traditionally restricted for the use in the inpatient setting. Now, with new legislation, Narcan is available for the use by patients and families in the outpatient setting to help avoid and prevent opioid-related deaths from accidental overdose. After IM or sub-Q injection begins, the effects begin within 2 to 5 minutes and persist for several hours. Elimination is via the hepatic metabolism, and the half-life is about 2 hours. Narcan cannot be used orally because the rapid first pass and activation. So, its therapeutic use. Narcan is the drug of choice for treating overdose with a pure opioid agonist. The drug reverses respiratory depression, coma, and other signs of opioid toxicity. It can also reverse toxicity from agonist-antagonist opioids. However, the doses required may be higher than those needed to reverse poisoning by pure agonist. Dosage must be carefully titrated when treating toxicity in opioid addicts. Again, because of the degree of physical dependence in these individuals is usually high. And therefore, an excessive dose of Narcan can transport the patient from a state of poisoning to one of acute withdrawal. Treatment should be initiated with a series of small doses rather than one large dose because the half-life of Narcan is shorter than that of most opioids. Repeated dosing is required until the crisis has passed. If the patient is receiving a dose of Narcan by a friend or family member for a suspected overdose, the patient should be transported to the ER, where providers to the nearest emergency department can provide further evaluation. In some cases of accidental poisoning, there may be uncertainty as to whether unconsciousness is due to an opioid overdose or an overdose with a general CNS depressant. When uncertainty exists, Narcan is nonetheless indicated. If the cause is poisoning, for example, from a barbiturate or another general CNS depressant, Narcan will not have any benefit, but neither will it cause any further harm. Other opioid antagonists. Methyl naltrexone, also known as Relistor, are selective mu-opioid antagonists indicated for opioid-induced constipation in a patient with chronic pain who is taking opioids continuously and who have not responded to standard laxative therapy. Benefits derive from blocking mu-opioid receptors in the GI tract. Both drugs work in the periphery and therefore do not block opioid receptors in the CNS. Accordingly, the drugs do not decrease analgesia and cannot precipitate opioid withdrawal. It is rapidly absorbed after a subcutaneous injection, reaching peak plasma levels within 30 minutes. It can be taken orally on a daily basis and has a slightly longer half-life, 6 to 11 hours. The medication undergoes minimal metabolism and is excreted in the urine and feces about 50-50. Primarily as an unchanged drug. The terminal half-life is 8 hours. Naloxone is metabolized in the liver and largely excreted in the feces, which is its other formulation. Adverse effects. Again, both are generally well tolerated. The most common adverse effects, however, can include abdominal pain, gas, nausea, dizziness, and diarrhea. In the event of severe or persistent diarrhea, the drugs should be discontinued. In a patient with known or suspected mechanical GI obstruction, the medication should be avoided. No significant drug interaction has been reported with methyl naltrexone. Naloxone should be used with caution in a patient who does take CYP3A4 inhibitors. So, Relistor is available in solution for subcu injection that goes into either the upper arm, abdomen, or thigh. Because defecation can occur rapidly, a bathroom should be immediately available. Dosing is done every 48 hours and should not exceed once every 24 hours. Dosage in a patient without cancer is given 12 milligrams subcutaneously daily. In palliative care patients, the dosage is based on weight as follows, and there's a whole criteria, so please hit pause to review that. In a patient with severe renal impairment, defined as creatinine clearance below 30 ml per minute, dosage ought to be reduced by 50%. The medicine should be stored at room temperature and be protected away from light. Naltrexone, also known as Revia, is given orally or IM as a pure opioid antagonist used for opioid or alcohol abuse. In opioid abuse, the goal is to prevent euphoria and the abuser should take an opioid. Because naltrexone can precipitate withdrawal reaction in a person who is physically dependent on opioids, candidates for treatment must be rendered opioid-free before the medicine is started. Although it can block opioid-induced euphoria, the drug does not prevent craving for opioids, so as a result, many addicts fail to comply with treatment. Therefore, therapy with naltrexone has been considerably less successful than with methadone, the drug that eliminates cravings for opioids while blocking euphoria. Use of naltrexone for alcohol dependence and opioid addiction is discussed in further detail in both Chapter 31 and 33. When dosage is excessive, Naltrexone can cause hepatocellular injury. Accordingly, the drug is contraindicated for patients that have acute hepatitis or liver failure. Warn patients about the possibility of liver injury and advise them to discontinue the drug if signs of hepatitis start to develop. Intramuscular administration can cause injection site reactions, which are sometimes severe, which would include pain, tenderness, induration, swelling, erythema, bruising, and pruritus. Severe reactions can include cellulitis, hematomas, abscesses, and necrosis, and can cause significant scarring and may require surgical intervention. Again, this medicine comes in two formulas. It's an excellent spot to hit pause so you can review them both. For oral therapy, the typical dosing schedule consists on dosing every other day, Monday, Wednesday, Friday, for instance. Alternatively, the drug can be administered daily in 50 milligram doses. For IM dosing, the usual regimen is 380 milligrams once a month. That takes us to the non-opioid, centrally acting analgesics. So, the big one here being tramadol, also known as Ultram, is a moderately strong analgesic with a low potential for dependence, abuse, or respiratory depression. The drug relieves pain through a combination of opioid and non-opioid mechanisms. Tramadol, or Ultram, relieves pain by the mechanism largely or completely unrelated to opioid receptors. The drug causes little or no respiratory depression, physical dependence, or abuse. So how does it work? Tramadol is an analog of codeine that relieves pain in part through a weak agonist activity at mu-opioid receptors. However, it seems to work primarily by blocking uptake of norepinephrine and serotonin, thereby activating a monoaminergic spinal inhibition of pain. Naloxone, an opioid antagonist, only partially blocks tramadol's effects. So its therapeutic use is approved for moderate to severe pain. The drug is less effective than morphine and no more effective than codeine combined with aspirin or Tylenol. Analgesia begins 1 hour after oral dosing to a maximum effect of 2 hours, but may last up to 6. Pharmacokinetics. It's administered by mouth and reaches peak plasma levels in 2 hours. Its half-life is 5 to 6 hours. It is eliminated via the hepatic metabolism and renal excretion. There are adverse effects to any good medicine. Tramadol has been used by millions of patients, and serious adverse effects are considered rare. Respiratory depression is minimal at recommended doses. Most common side effects include sedation, dizziness, headaches, dry mouth, and constipation. Seizures, however, have been reported, and therefore the drug should be avoided in patients who have epilepsy or neurologic disorders. Severe allergic reactions can occur. Although they are generally safe, tramadol can be fatal in overdose, especially when combined with other CNS depressants. So, its drug interaction. It can intensify responses to CNS depressants, alcohol, benzodiazepines, so these drugs shouldn't be used together. By inhibiting the uptake of norepinephrine, tramadol can precipitate a hypertensive crisis if combined with a monoamine oxidase inhibitor. Therefore, the combination is absolutely contraindicated. By inhibiting the uptake of serotonin, tramadol can cause serotonin syndrome in patients taking drugs that enhance serotonergic transmission. Among these are SSRIs, serotonin and norepinephrine reuptake inhibitors, tricyclic antidepressants, MAOIs, and triptans. If these drugs must be combined with tramadol, the patient should be monitored especially carefully during initial therapy and times of dosing escalation. Its abuse liability is considered very low. Therefore, tramadol is classified Schedule 4 under the Controlled Substance Act. The report of abuse, dependence, withdrawal, or intentional overdose, presumably for subjective effects. Consequently, tramadol should not be given to patients who have a history of drug abuse, and the recommended dosage should not be exceeded. Suicide. Tramadol can be a vehicle for suicide when taken alone and especially when combined with other CNS depressants. Tramadol can cause severe respiratory and CNS depression. Deaths have occurred, primarily in a patient with a history of emotional disturbance, suicide ideation or behavior, or misuse of alcohol or other CNS depressants. So to reduce the risk, tramadol should not be prescribed with patients who are suicidal or addiction or prone and should be used with caution in patients who are depressed, taking sedatives or antidepressants, or prone to excessive alcohol abuse. Finally, its preparation, dosage, and administration. The medicine is available alone or in combination with Tylenol. Tramadol alone has 3 formulas. Again, it's an excellent spot to hit pause so you can see the different dosages and different names for the medications. It does have immediate release medication tablets called Ultram, as well as extended release, also known as Ultram ER. Again, for patients who are currently taking IR tramadol, the dosage is 100 milligrams once a day initially, then titrated every 5 days to 100 milligram increments to a maximum of 300 milligrams. Dosaging can be titrated up or down as needed. Again, extended release tramadol should not be used in patients who have severe hepatic or renal impairment. Finally, tramadol combined with Tylenol, known as Ultracet, is indicated for short-term therapy of acute pain. And the recommended dosage is 2 tablets every 4 to 6 hours, and treatment should not exceed 5 days. And that concludes our chapter here for today. I thank you for listening as always, and I hope you have a wonderful rest of your day. I'll see you at the next chapter. Thank you, and have a good one.